Hello, everyone. Welcome to this European Association of Neurosurgical Societies webinar. My name is Ahmed Toma. I'm a neurosurgeon. I'm based at the National Hospital for Neurology and Neurosurgery at Queen Square in London, the United Kingdom. This webinar is about idiopathic intracranial hypertension, also known as pseudotumor cerebri, or some people still call it benign intracranial hypertension. It is a rare disease, yet this is the second webinar arranged by the NICSF task force about this diagnosis. This reflects the impact this disease has on the quality of life of sufferers in terms of the daily disabling headache, as well as the risk of losing vision, and also the reflex this will have on us as surgeons and the healthcare providers. I am delighted to be joined by two experts in the field from Queen Elizabeth Hospital in Birmingham here in the UK. So the first talk will be done by Ms. Susan Mullen, consultant neuro-ophthalmologist, and she is going to talk to us about the pathophysiology and what drives IIH. Then we'll have Mr. George Chermolos, who's a consultant neurosurgeon, who's going to talk to us about the recommendations for CSF shunting in this diagnosis. We should have time for questions after each talk. Please use the question answer tab at the bottom of the screen. Do not use the chat box. And we should also have time for further discussion at the end of both talks. So without further delays, I would like to introduce Ms. Susan Mullen, who is trained in ophthalmology at the West Midlands and Oxford here in the UK. She had further advanced neuro-ophthalmological training, and she's a consultant at the University Hospital Birmingham NHS Foundation Trust. She's active in research within a well-known team investigating rare diseases involving the brain and the eye. This includes idiopathic intracranial hypertension, giant cell arthritis, and she's also researching development of quantification of disease through ocular imaging. She has authored the famous first IIH consensus guidelines in 2018, among many others. And she's a keen educator, regularly chairing and speaking in national and international symposia. And she's also an active committee member of national, European, and international neuro-ophthalmology societies. I look forward for Susan's talk, and I'll pass the microphone to her. Thank you, Susan.
Thank you very much for that warming invitation. It is a real pleasure to speak again on idiopathic intracranial hypertension. And as Ahmed's pointed out, it is a rare disease, but it is becoming much more common. So I have some disclosures, one of which relates to idiopathic intracranial hypertension, which is Invex Therapeutics, which is a spin-out company from the University of Birmingham looking to repurpose a medication for idiopathic intracranial hypertension. Now, IIH really polarizes our patients and doctors, and there are lots of reasons why it polarizes both communities, both healthcare professionals and patients. And one of the main reasons is that lots of different doctors treat this condition. So if you're an ophthalmologist or a neurologist or a neurosurgeon, you're going to have a slightly different focus on the disease, and we're going to sort of talk about that as we go through the talk. As Ahmed mentioned, there's a number of different helpful working documents that we've put together in the UK and in Europe to really help guide the general neurologist, ophthalmologist and neurosurgeon in the disease, so that we can start to have uniform management of these patients. And so I'm going to go back to what do I mean by idiopathic intracranial hypertension, because it is a word that gets used for lots of different conditions, and really what's the current thinking in the biological underpinnings of the disease. So when I think about typical idiopathic intracranial hypertension, I think back to the diagnostic criteria by Friedman et al., and I look for papilledema a normal neurological examination, normal brain imaging, normal CSF constitutes, and the pressure being over 25 and lumbar puncture opening pressure. I also start to think about my patient, exclude those things such as drug causes and other things that we put into secondary pseudotumor, and I think about recent weight gain. So the patients that I'm thinking about today are 90% of my IIH clinic that have typical disease. And really, we started to think a long time ago in Birmingham as to what drives the disease. And we'll talk a little bit about the phenotype of the patients, that 90% are overweight with recent weight gain. The majority of these patients are female. And the jury is still a little bit out on whether this is a CSF overproduction or is it actually a problem with drainage or a problem with both. And the problems about this condition is the understanding of the disease is poorly understood. The treatment's really difficult because we know weight loss puts this disease into remission, and that's really difficult to achieve. There are barriers to weight loss. The treatments that are out there that we have for reducing brain pressure are not that well tolerated, and the science behind them is actually quite old and slightly inappropriate when you look at the doses that were used in animals for this. And care around Europe is actually very different for each patient. So these become challenging patients, and it's a really challenging disease. What we've shown over time is this disease is becoming much more common. And one of the major reasons for it becoming much more common is the obesity epidemic. And that's mirrored in countries that have increasing obesity rates. We know that it's a disease of a young age group, so working women tend to be affected in it. And the problem is these patients access our hospital services, particularly in the NHS, in repeat admissions through an A&E or through emergency admissions. They tend not to use the normal care routes that other diseases might meet. And this makes it a real challenge because we've got lots of different doctors treating the patients. And the first study I showed you there was really in looking at secondary care, so hospital data. And what this study shows is it shows primary care data. So what's happening across the UK in this database. And again, it shows exactly the same thing the secondary care data showed, that the incidence and prevalence is rising. And then on the right-hand side, you'll see at what point do these patients really start to have an impact on their BMI, on being diagnosed with IIH. And you can see that once you start to get out of a normal range, 24, 25, this disease really starts to take off, and really at about a BMI of 30, it becomes a much more common disease. So we're absolutely convinced that this is a disease of a population of obese women of childbearing age. And what both these studies showed really for the first time was it's linked to patients with lower socioeconomic class and social deprivation. And this is important because this links back to how these patients interact with healthcare. And there's lots of very good information about people from underprivileged areas and how they interact with hospital services. So these patients have signs and symptoms, and they tend to be of headache, of vision, and also other things, including neck pain, back pain. They get a cognitive disturbance, and our patients talk about brain fog. And it's important to know that these symptoms and signs aren't just from IIH. And as doctors, we know this when we meet other patients. And this study done by Rigmor Jensen Group was very good because it took patients in a headache clinic that had migraine and matched them to IIH patients. And you'll see that even in the migraineurs, they got blurred vision, pulsatile tinnitus, and visual obscurations. And one of the important things out of this study, it showed that 1/4 of migraineurs got relief of their headache following lumbar puncture. And so how I think about IIH is I split the patients up into that benign disease of really where the old name came from, those patients that had a low risk of visual loss, and those patients that have a high risk of visual loss that would be related into the neurosurgical services. And they form about 7% of the overall patients. And for the rest of the patients, the real issue is headache, and headache determines their quality of life. And as we think about headache in this condition, headache attributable to IIH is kicked off by raised intracranial pressure. And over time, as the ICP resolves, in probably about 30% of these patients, we get this post-IIH headache that's very persistent and actually quite difficult to treat. One of the things that is important that we've been finding out more about is IIH is not just a neurological disease. And then going back to our primary healthcare database, we were able to find that they had an increased risk of cardiovascular disease. And this is important because it starts to build a story that this is much more of a metabolic illness that is distinct from simple obesity. And herein is the issue, is when we looked at these patients, we really controlled for gender, age, and BMI. So this is not obesity necessarily playing into it. This is other parts of the condition. So we know these patients have an obesity problem. They have disabling headaches. Some can have visual loss. There's this underlying feeling of metabolic dysregulation with the increased cardiovascular risk. Many of our patients can have low mood and anxiety, which may be related to their difficult headaches, which are difficult to treat. And we have this brain fog and fatigue. And so when we think about what we know about the clinical phenotype is, why are the patients all female? What factors are driving this? We know weight gain precipitates the disease, weight loss induces remission, and certainly weight gain, regaining the weight that you've lost, will precipitate a relapse, and this emerging picture of metabolic dysregulation. And so here in Birmingham, we're very lucky to be part of this translational research portfolio headed up by Professor St. Clair, of which myself and Mr. Salumas are part of. And in the last 7 years, we've been really running a number of different clinical trials, which the data is now just starting to come through. But putting the really carefully phenotyped patients into clinical trials allows us to use the lab knowledge to really work out what is going on to drive the illness. And so I'm going to take obesity to start with. All our patients had various fat samples sent to the lab, both from the abdomen and other subcutaneous fat, of which the lab team have been able to analyse. And when we went back to our original weight loss study, we started to wonder whether the fat distribution was different in IIH patients compared to normal simple obesity controls. And we know that body mass index does not correlate with LP opening pressure in IIH. I'm not talking about the normal distribution, I'm just talking about IIH, but truncal fat mass did correlate with IEP pressure, and truncal fat loss did correlate with clinical resolution of the disease. Just move forward. So is truncal fat mass important? And is it the truncal fat mass that's driving the increased cardiovascular risk? So taking this forward into the more recent studies that we've been doing, this is some of the high-level information we will hopefully be publishing soon, that our IIH patients have an insulin resistance type phenotype. This is, we've reconfirmed this preferential truncal obesity in these extra 100 patients we've recruited to our trials. We've confirmed that lumbar puncture opening pressure correlates with total fat mass and truncal fat mass. And our patients have this comparative hyperleptinemia, and leptins have had a big story in IIH, and really we wanted to explore that because obviously leptin has a very important role when we consider centrally at the hypothalamus and thinking about satiety and that feeling of fullness. And what we find is although they have systemic insulin resistance, the hyperleptinemia is probably more related to that, as it doesn't seem to percolate through to the CSF. And what was really interesting about our IIH patients is the adipose tissue is different. So when we look at transcriptional factors within the adipose tissue, they're actually primed for lipid accumulation compared to normal obese controls. And the other thing is morphologically, the fat is different as well. And all these factors are feeding into the fact that this rapid weight gain that a lot of our patients explain to us as precipitating the disease studies, has controlled a different type of obesity mass that is now likely driving the condition. So we move away a little bit from obesity and start to think about female gender. And female gender is important for IIH. A lot of our patients come with women-related other conditions, such as polycystic ovarian syndrome. And what we want to do is really tease out what's distinct about IIH over polycystic ovarian syndrome compared to, again, matched controls. And the team did some very sophisticated profiling of the blood, of the urine, and of the CSF. And we're obviously very important to exclude all those secondary factors that we touched on earlier, including venous sinus thrombosis. And through that work, we find there was a very unique androgen signature found in IIH, which is expectantly different to what we thought we might find. And instead of the female hormones driving the disease, we find that there was a significantly raised testosterone in the serum, significantly raised CSF androgens, and also raised systemic 5-alpha reductase activity. And so running through this is thinking about, is this a condition of production or more of drainage? And certainly when we started to look at production, we thought, well, are these androgens driving IIH? So to do that, you've got to first look and see whether there's androgen receptors expressed in the choroid plexus, and how does it alter CSF production? And many of you on the call will know that the sodium potassium ATPase channel is the primary driver for CSF production. And again, through careful experimentation, the team were able to show that androgen receptor is expressed in human choroid plexus. And when you look in an animal model of the choroid plexus line, testosterone significantly enhances the activity of it, which is obviously the surrogate of CSF secretion. So what we've established is testosterone, which we know is abundant in our IIH patients abnormally, is actually increasing our CSF secretion. And not only that, testosterone is upregulating our carbonic hydrase 2 and 3 expression in the choroid plexus. So we go back, circling back round. So where are these androgens being generated from? And going back to the actual tissue, we were able to show that it's actually the augmental adipose tissue that's producing these androgens. So the rapid weight gain that our patients put on is in the truncal region, which is augmental fat, and that is what's producing the androgens, which is causing abnormal CSF secretion. So thinking about the conclusions to this, IIH is characterized by a very specific androgen metabolic profile. It is driven by testosterone, and testosterone is increasing the CSF secretion. And so our hypothesis is that there's a pathological window of circulating androgens. And this is very common when you talk to endocrinologists for this sexually dimorphic actions of hormones. So our male patients, if they drop into low testosterone, they may be precipitating IIH picture. And for women going up on their testosterone levels, it may be driving the disease. I thought in the last few minutes, I would just do a sneak preview of where else we're going with some of our research, which is interesting. We think again about CSF production, and when we think about the choroid plexus, it's really a mirror of what happens in the kidney. And that's often why we've had medicines such as Diamox, furosemide, spironolactone being tried in IIH. And I wanted to take you to Glucagon-like peptide 1. So GLP-1 inhibitors are really successfully used for weight management, aiding weight management in diabetes. And recently the STEP 3 trial has just shown superior weight loss in normal individuals, so overweight individuals without diabetes. And so that's the kind of background for the safety of GLP-1 inhibitors. But coming to IIH, GLP-1 is a gut peptide. It stimulates glucose-dependent insulin secretion, and it lowers blood glucose. And it's also synthesized in the neurons of the nucleus tractus solaris, which project obviously to the hypothalamus. And this is the thing that produces satiety and weight loss. And what we wanted to show was that it was expressed in cells in the choroid plexus. And so, again, the team in the lab did some very careful experimentation over a number of years to show that it's found in human and rat choroid plexus. And we were able to modulate it by using a GLP-1 inhibitor, Exendin-4, and it reduced the sodium-potassium ATPase activity, indicating reduction of CSF secretion. And when that was used in the animal model, it lowered ICP compared to saline within 10 minutes of treatment. And it had a cumulative effect. Over 6 days of dosing, the range of ICP got lower and lower. And that was done in normal animal models. And the animal model was then moved to a hydrocephalic rat, because we don't have a good model for IIH. And again, it showed significant improvement. In fact, it showed a 45% reduction in ICP. And that's been taken forward. And I think Mr. Salumis may talk very slightly about the IIH pressure trial. These were very special patients, of which we were able to put in a ROI medical monitor. And that should be hopefully reporting at the European Neurological Society meeting in Hamburg later in the year. So more information to come from that. So when we think about IIH, we know that they have increased truncal obesity, driving the disease, increasing their intracranial pressure. We now have a number of different ways to start to target the disease. I mean, obviously, primary prevention would be the key, but for many of our patients, we will be hopefully working on more effective treatments for their disease. So in this short talk, we talked a little bit about IIH and a little bit about the current thinking and the biological underpinnings of IIH. I'd like to thank Alex Sinclair and George Salumis, who are my good colleagues in Birmingham, and I'd like to take any questions.
Thank you very much, Susie, for this brilliant talk. We have 3 questions from the audience. I have a question from Viraf Cooper. How long does it take for papilledema to resolve following successful treatment?
So it depends what you mean as successful treatment. When Mr. Salumis puts a shunt in, I see about a third of reduction, usually within a week. Typically, we would say by 3 months, we would have no papilledema at all. But more recently, I think that's down to clinic review. So I think it actually happens much sooner. So if you were to put in a shunt of somebody with sight-threatening papilledema and things are going well, it resolves very quickly. And we saw exactly the same thing in the weight trial. So patients that had bariatric surgery, within a very short space of time, we saw them within 2 weeks, their intracranial pressure was much lower. And that's to do with the neuropeptides rather than weight loss. In our patients with weight loss, it takes a bit more time.
Perfect, thank you. And there's another question from Professor Marek Czasnika. Is there evidence that in IIH, CSF production is increased?
Yes, so that's exactly what we believe is part of the main driver, is that we get increased CSF production. What we've not explored in Birmingham, but I know the Copenhagen group have been exploring, is also the drainage. So there is a big story in nasal glial lymphatics and glial lymphatics in the brain, but also the arachnoid granulations. And it is a story, it will be a story of balances, but I truly believe in spending time with these patients and how the disease comes about. I think the initial driver is CSF oversecretion. Thank
you, Susie. I think we have time for one last question, which is one from Thomas Ches. How would you explain, one, the level of increased ICP in IIH, and second, the rarely enlarged ventricles?
So I'm going to deflect this probably to my neurosurgery colleagues, yourself, Ahmed, and George, because in my last talk, there was comments about the slit-like ventricles and understanding the origins of that and compliance. I don't have a good answer for that yet. So.
Thank you very much, Susie, for your valuable time and excellent talk today. And I look forward for future talks and results of your excellent research. Thank you. Now, I would like now to introduce my colleague, Mr. Chermolas, who has been a neurosurgeon at Queen Elizabeth Hospital in Birmingham since 2017. He's also an honorary senior lecturer at the University of Birmingham. He trained in neurosurgery in Greece and the UK and has subspecialty training in neuro-oncology, pituitary and skull-based surgery in Toronto. His special clinical interests are disorders of CSF circulation, cranial neurotrauma, and endoscopic pituitary and skull-based surgery, as well as neuro-oncology. Has master's degree in clinical research from Newcastle University and postgraduate certificate degree in global health from the University of Toronto. He is a council member of the British Skull-Based Society, and he has been amazingly involved in global health work in Gaza and Rwanda. So I pass the microphone to George. Thank you very much, George, and I look forward for your talk.
Thank you very much, Ahmed. I'm going to talk about recommendations on CSF shunting in idiopathic intracranial hypertension, no conflict of interest, and the surgical treatment of IIH. It's not only CSF shunting. We do optic nerve sheath fenestration, which is not very common, venous sinus stenting, and bariatric surgery for weight management, which is not, of course, done in the acute setting. And for CSF diversion, we have many shunts. The most common are the ventriculoperitoneal and lumboperitoneal shunts, but we also do ventriculoatrial, ventriculopleural, and lumbopleural shunts. And before I go further, I'd like to post the first out of the 3 poll questions for our audience to vote. And I'd like to know what type of shunt do you use for your IIH patients? A VP, an LP shunt, or some other type of shunts? And there is no right or wrong answer. The most common ones are VPs and LPs. And if you do both, just put the one that you prefer or the one that you mostly use. And let's give it a few seconds and see what your responses are. Can we have the results, please?
Yeah, actually, we are still getting some answers. So let's wait for another few seconds. I see the number growing.
Sure. They all do the same job. They all divert CSF from the CNS, either from the ventricle or from the lumbar theca to a receptacle in the body, peritoneal cavity, pleural space, or the heart. And in theory, they should all work, but of course, some work better than others. And the type of shunt is not only based on evidence or what's published in literature. It's primarily probably due to surgeons' preference and due to the way we were trained and what our experience and expertise suggests.
Okay, we are ready to end the poll. And I'm sharing the results. So
that's quite interesting. 69% of you think that a VP shunt is better, and 32% for an LP shunt, and 2% of other types of shunts. And that's probably what's reflected in literature. And this is a table of studies that over the last 10 years that report on revisions for IIH shunts. And revision is probably the best proxy indicator for complications of shunt surgery, because most of the complications require a shunt revision, and as surgeons, we analyze and we evaluate our outcomes based on partly on the complication rate. Some of these studies also report visual outcomes or headache outcomes, but mostly our surgeons, we analyze our complications rate. The first study is the only multi-center study that I have found to report on shunt revisions for my IIH, and the other studies are all single-center studies. And I'll discuss about the first two in some detail. Most of them report on patients between 20 and 50 patients, and the revision rate varies from about 10% at 3 months up to 60% during the study period. And most of these studies are on VP shunts and LP shunts. The fourth study down the line by Tarnaris in 2011, also Mr. Thomas is an author on this study from Queen's Care in London. They found that VP shunts and LP shunts have similar visual and headache outcomes, but LP shunts are associated with a high revision rate, and VP shunts are probably more reliable and live longer. And this is probably what is replicated in the majority of the literature. And more recent literature reports more on VP shunts rather than LP shunts. Further down the table, you see that some people put ventriculoatrial shunts or ventriculopleural shunts or lumbopleural shunts. The only limitation in this study is the small number. In theory, it may sound attractive not to put a shunt in the peritoneum of a patient with a high BMI, in obese patients, but this type of procedures are not common, and you see that the revision rate is not significantly lower compared to the other studies. In 2011, Professor Sinclair wrote a paper on shunt revisions in Birmingham over the previous 10 years. The majority of the shunts, 92%, were lumboperitoneal shunts. And during the study period, the revision rate was 51%. The revision within 1 month was 23%. And in the first year was almost 63%. And this revision rate is quite high compared to other VP shunts. And in this study by Merkel et al. In 2017, which is the largest study that reports on shunt revisions for IIH, was essentially a study of more than 17,000 patients who had a VP shunt for any etiology, and out of them, 424 patients were IIH. And this study showed that patients with IIH have the higher risk of revision. And this is again replicated in literature, and it is our experience as well. In Birmingham, in July 2019, we introduced a protocol for shunting, which also included a section on shunts for IIH. And we only put shunts in IIH when the vision is deteriorating. It's a procedure to divert CSF in order to save the vision. We have stopped putting shunts for headache management. Shunts are not a good treatment for headache. And the background of those guidelines of this protocol for shunts for IIH comes from guidelines from the consensus guidelines that Ms. Mullen wrote back in 2018. A departmental audit that looked at our shunt revision and the literature. And the consensus guidelines on IIH recommended that in fulminant IIH, where the vision is threatened, CSF diversion should happen urgently within 24 hours. And if a shunt, a permanent shunt, or optic nerve sheath fenestration cannot happen within 24 hours, then we should put a temporizing lumbar drain. Most of the experts suggested that a VP shunt is probably better than an LP shunt, and the shunt operation ideally should be carried out by a surgeon with expertise and experience in CSF disorders. In 2019, we also looked at our early shunt revision rate, and we looked at the previous 5 years, and our 30-day shunt revision rate was about 12%, which was in keeping with the published literature. Anderson and al. In 2018 published a study from Leeds in the UK that showed that the 30-day shunt revision in adults for primary shunts was 17.7%. And in a more recent study from Lee, the relevant rate was 12.4%. And in our audit, this was shunts for all etiologies. The revision rate for VP shunts was lower. Found that the indications for shunting also influence the early revision rate. The lowest was with NPH, and the highest revision rate was with IIH patients, 22%, similar to the study by Professor Sinclair a few years back. So in 2019, July 2019, we introduced what we call the Birmingham Standardized IIH Shunt protocol for insertion of shunts in IIH. Several components. The first one is that the operation should be carried out by a surgeon with expertise in CSF disorders. And in Birmingham, it's 2 out of the 8 cranial neurosurgeons in the department. We prefer a frontal VP shunt, usually on the right side, but occasionally we put a left VP shunt if the left lateral ventricle is larger. We use the ProGAF system by the Mitke company. We use the ICP monitoring device, again by the Mitke company, which is, I prefer the sensor pre-chamber compared to the Berhol sensor reservoir. And this is integrated in the shunt system, and with a reader you can measure the ICP pressure. I'll expand on this later. We use Axiom as the frameless image guidance technique, and I think in all shunts now, a neuronavigation system is used in most centers, especially in patients with slit ventricle. And from the distal end, for insertion in the peritoneum, we now prefer the laparoscopic technique to the mini laparotomy technique, given the high BMI and the truncal obesity in these patients. And before I go any further, this is the second poll question. Which site do you prefer for your VP shunt in slit ventricles? Right frontal, right parietal, the larger ventricle, which can be either frontal or parietal, or do you not use VP shunts and you use lumbar shunts for slit ventricles? Again, there is no right or wrong answer. Since July 19 in Birmingham, we use a frontal shunt in the larger ventricle. I know traditionally we use a right-sided approach, but as I said, in some cases, we use the left side in Birmingham. So it'd be interesting to see how many of you prefer a frontal versus parietal shunt. I used to put all my shunts through a parietal trajectory, and I've only changed my practice for the IIH shunts. I also sometimes use LP shunts for slit ventricles, but only in patients that are not willing to accept the risks of the cranial part of the procedure, the very small risk of seizures, very small risk of intracranial hemorrhage. And in the UK, there are driving regulations. If a patient has a VP shunt inserted, then they cannot drive for 6 months due to the slightly raised risk of seizure compared to the general population. So I offer my patients both type of shunts, both a VP or an LP shunt. I tell them that our preference is for a VP shunt, and only very few choose to go for an LP shunt, primarily due to the driving regulations.
Okay, we are ready to end polling.
All right.
And sharing the results.
Okay, that's a bit of a surprise to me, but a pleasant surprise actually, to see that there are people that cannulate the larger ventricle, even if that's the left one. And quite a few of you use the frontal trajectory, and there is about a quarter that uses lumbar shunts. And this slide shows the impact of the protocol in our practice. We have written a paper that we'll submit we'll submit for publication of our study. It's almost ready, and this is 81 patients that had a primary shunt for IIH. 45 of them had the shunt before the protocol in July 2019 and 36 after the protocol. And we have shown that the early revision rate within 30 days was significantly lower following the introduction of the protocol, 6% compared to 22%. As expected, the total number of revisions within the 30 days was significantly lower after the protocol, 2 versus 19. And we also looked at the revision rate between 30 days to 1 year, and statistical comparison is not applicable in this case, because many of the patients from the second group have not completed the 1 year follow-up, but so far we have not revised any shunt that we put since July 2019. And traditionally, more VP shunts are put on the right side, either frontal or parietal. And I used to put all my shunts through a right parietal trajectory. up until 2019, when I changed my practice. And this is how I was trained, and this is how the practice was in all the neurosurgical units I worked. And I still put parietal shunts, but not in slit ventricles. And this is the last case back in early 2019 that I've tried to cannulate slit ventricles through a parietal trajectory. And as you can see on the left image on the CT scan, day 1 post-op, the shunt is on the contralateral hemisphere in the deep white matter. Of course, it was not draining. The neuroophthalmology assessment confirmed that the papilledema had not reduced. So on day 1 or day 2, I took the patient back to theater. I took the catheter out from the parietal burr hole and inserted it on the right frontal horn. And post-revision, the papilledema improved and the patient was much better. Actually, there was a paper, a Swedish paper from 2019 that suggested that the frontal placement of the ventricular catheter is associated with a lower revision rate. And the reason I think that it is easier in slit ventricles to cannulate the frontal burr hole is because for the registration of the neuronavigation system, we use the facial morphology. And the further away the target is from the face, the higher the target registration error, and the harder to hit the ventricle, to hit the target, the further away from the registration. The other reason is that if the registration fails, or if you run into problems intraoperatively and you cannot hit the ventricle, you cannot get CSF, we can use the ultrasound as a real-time imaging modality to try and place the catheter. And this is the coronal ultrasound view of a patient with large ventricles, and you can see a nice configuration of both lateral ventricles and the third ventricle through a frontal trajectory. In patients with small ventricles, you cannot necessarily see where the CSF spaces are, but you can always see the falx, and you can estimate where the ipsilateral ventricle should be. So it's not a completely blind procedure, even if you cannot use your frameless neuronavigation technique. Through a parietal burr hole, we're not familiar with the ultrasonic, at least I'm not familiar with the ultrasonic anatomy, and it's quite difficult to fill the burr hole with saline to get a nice ultrasound picture through a parietal burr hole. So only in slit ventricles, I've now changed my practice, and we put a frontal shunt. And as I said, we put traditionally all VP shunts through the right side because of the risk of damaging the speech centers if we run into complications with intraoperative hemorrhage or a post-op hematoma, and we don't want to damage the dominant left hemisphere. And in the majority of patients, I put the VP shunts on the right side. But in some cases of slit ventricles, I prefer the larger ventricle, and in a minority group, it is the left. So in these patients, I put a left VP shunt. And these are two of the very few patients that I have put a left VP shunt for IIH. And this is mainly due to two reasons. The first one is that it is easier to hit the larger ventricle. That makes sense, especially on this second patient. You see that the difference is pronounced. In this patient, the first one, the difference is subtle, but I think it's still there. And even if you try to hit the right ventricle in these cases, there's a good chance that your ventricular catheter will end in the contralateral ventricle. I've done it a few times. It's fine. It's still working. It's not a problem. And in some cases, I've also put the shunt in the very few cases in the third ventricle. Again, the shunt is working. It is the papilla edema is reducing. It's an acceptable outcome. But the second reason is that in some cases, when you shunt the ventricles, you see preferential drainage of the shunted ventricles, and we can see that in big ventricles, in normal size ventricles, and in slit ventricles. The shunted ventricle reduces in size. But I think that in slit ventricles, this has some clinical relevance. And you see here that the collapse can be either early after the operation, or it can be several days later. And you see that the collapsed ventricle may transiently obstruct the ventricular catheter and lead to intermittent malfunction of the shunt. This is not supported by, what I'm saying now is not supported by robust evidence. It is just my my theory. And in fairness, I never had to revise one of those shunts. But this is one of the reasons that I prefer the larger ventricle, even if this is the left. And again, the risk of damaging the dominant hemisphere, the left hemisphere, as a consequence of post-op hematoma, in my experience, is negligible. I've never seen post-op hemorrhage in following a shunt for IIH, and in some cases, we do not cannulate the ventricle with the first pass, 2 or 3 or even multiple passes. I've seen it in other conditions, in NPH, for example, and these are elderly brains with amyloid angiopathy, but in IIH, which are young brains, I think the risk of post-op hemorrhage is close to 0. And in my opinion, the risk of not cannulating a very small ventricle could justify taking that risk and putting the cannula, putting the catheter in the larger ventricle. And the way we do the operation in Birmingham, we do 2 cranial incisions, a curvilinear incision over the cochlear point in the frontal area, and a smaller straight incision in the parietal area. We cannulate the ventricle. This is a deflector that sits in the burr hole to give the tube the right angle, the sensor pre-chamber, and the valve, and we insert the peritoneal catheter laparoscopically in the in most patients with a high BMI. And of course, after the operation, we obtain post-op imaging, a CT scan, and shunt X-rays to make sure that the catheter is in the right place. There is no kinking or disconnection of the tube. Equally importantly, our neuroophthalmology colleagues assess the patient. We want to make sure that the papilledema is reducing to the rate that is in keeping with the functioning shunt. And since July 2019 that we start using the sensor reservoir, we also obtain baseline ICP recordings. And Marian, our clinical nurse specialist, does a fantastic job in following up these patients. We'll see them on day 1 or 2 postoperatively, and with a reader, which also has an SD card that stores the data of individual patients. We'll get ICP recordings for about 2 minutes in the sitting and the supine position, and we document the mean pressure in patients' records. And since autumn, I think last year, we have also we have access to this online software where we can analyze our ICP recordings in more detail. And this is a short footage from my computer screen that will show you how we use this software. So this is the data for the patient. We put them in the software, and this is the ICP waveform that we can zoom in. The pressure on the x-axis, the time on the y-axis. We can get the mean pressure. We can get the amplitude of the waveforms. We can move to any part of the reading and analyze that particular part of the recording. And you see here the ICP waveforms. The software can give us histograms of the pressures. We can record the valve setting, the position, how the patient is, and we can store this data. We can export it also in a PDF format, and this is what we prefer in Birmingham. And this, we can print the PDF and put it in the patient's record or store it in an electronic form. And we have it for future comparison when, for example, the patient becomes unwell and comes with headache. We can compare the recordings at that particular point in time with the baseline recordings. So let's look at the ICP waveform in some detail. And in neurosurgery, we're more experienced with ICP waveforms in head injury. And the ICP bolts that we have in our ITUs for our TBI patients have a frequency of about 100 hertz. And we can see nicely the P1, P2, and P3 waves. And we can also see the waveforms that is generated both by the arterial pressure and the respiratory cycle. In a similar way, with this piece of technology, we can see the large undulations from the respiratory cycle. And the frequency of this device is 44 hertz. And when you zoom in, you can also see the P1 and P2 waves over time. You can analyze them. And this is in keeping with a functioning shunt, at least functioning from the ventricular catheter to the sensor reservoir, because you can get the waveforms. And the mean supine pressure we see in our patients is about 24-25 centimeters of water. And the range is, we see a range from 15 up to 35. And in the sitting position, the mean pressure is -5. And we normally see negative pressures in the sitting position. And sometimes we see low single figures as well. In many patients, we don't get the nice waveforms that you see on this at the top two graphs, but sometimes we see a waveform without a typical pattern due to some sort of noise. But even on these waveforms, we can often see some ICP waves. This is not, we're in the process of understanding this technology. We haven't completely analyzed our results, and we don't rely heavily on this technology for clinical decision making. We rely primarily on the visual outcomes and the reduction in papilledema in the OCTs. But I think this, once we get to know more about ICP in IIH, and once we understand better the different patterns, then I'm pretty sure that we'll use this technology in a more meaningful way for clinical decision making. So, as a last slide, I'd like to ask you which component of the Birmingham Standardized IIH Shunt protocol you think it's more useful, which one you like more, or if it's something that you'd be interested in, which component would you introduce in your clinical practice. Of course, you can introduce all of it if you like it. You may have already a protocol that works well for you, but I think having an open mind, it is so surgeons with expertise in CSF disorders, frontal VP shunt, the adjustable gravitational valves, the acid monitoring device, frameless neuronavigation, or laparoscopic insertion of distal end. And I think the software gives you only one choice.
I think we can choose more than one, actually, George.
All right, okay.
Yes,
Feel free
indeed,
then.
it's multiple choice.
Multiple
in
choice,
case someone
right.
feels in between the answers.
Okay then. So some people may choose all of them and be delighted.
We are still getting some answers.
I'm not entirely sure which component of the protocol significantly improved our early revision rate. And in the paper that we'll submit for publication shortly, we could not do this type of analysis because the power of the study was low to look into it. I'm pretty sure that in follow-up studies, we look into the factors that are associated with early shunt revision. Okay, so about 40% surgeons with expertise in CSF, and I think this is fair to say. IIH surgery is considered low volume surgery. In most of the studies that we looked at, the frequency of insertion of an IIH shunt varies greatly from 1 a year to about 1 a month. And in Birmingham, we have one of the largest IIH services in Europe, if not the largest, and we insert about 1 IIH shunt per month, which is so it's not common. Frontal VP shunt usually right about a quarter of you. 35% like the ProGAF system, and in Birmingham we use valve from many manufacturers for hydrocephalus, but for the IIH group, I much prefer the ProGaf valve because you can fine-tune the drainage of CSF, and I think it is one of the best valves to address the issue of CSF over drainage, and we're very satisfied with the with how these valves work. The majority of you like the ASIP monitoring device, and in our experience, this is an exciting new technology. I'm not sure if I don't think there are other ASIP monitoring devices in the market that are integrated into the shunt. The ROMedic monitor that we've used, we still use. It's a standalone monitor, and in my opinion, the indications are different. And these patients, as Ms. Mullins said, come to A&E quite often. They are patients that have a headache and they get a CT scan straight away. So I think the biggest advantage, in my opinion, of these ASIP monitoring devices is to rule out a shunt malfunction. The patients do not get a CT scan, do not get X-rays. We measure pressures, we analyze the ICP waveforms, and we can say if a shunt is functioning or not. Of course, the best investigation is to look at the eyes for recurrence of papilledema. That's the standard investigation. But as we analyze, as we understand the ICP recordings better, I think this technology will probably transform our approach to patient with IIH comes with headache, what we do. Frameless neuronavigation, 36%. So I think image guidance in this age and age is standard practice, should be considered standard practice in shunt insertion. And in Birmingham, we use it for all shunts, for all EVDs. I think that the freehand technique for cannulating the ventricle should stop. You may get it right 90 out of 100 cases, but if you don't get it right with if you don't get it right with a freehand technique, then I think you're open to criticism. And 19% laparoscopic insertion of distal end. Again, IIH have certain technical challenges. One of them is the large body high BMI, and I think that laparoscopy is an underutilized resource, at least in our setting, or was until recently, because studies have shown that they reduce the risk of malposition and the risk of migration of the distal catheter. And in some centers, I know that neurosurgeons insert the shunts laparoscopically. In most centers, like in Birmingham, we rely on the availability of general surgeons. But I think it is important to streamline a pathway for laparoscopic insertion of the shunt, either with the help of general surgeons or by building capacity in-house within the neurosurgical departments. The take-home message is that the Birmingham Standardized IIH Shunt protocol works well in Birmingham. You may have a very good protocol in your unit, and but in our unit, it has really transformed the care we provide to our patients. Feel free to adopt the whole protocol or part of it, but I think the take-home message is that you should standardize your surgical pathway for IIH patients. This is a challenging type of shunt, a challenging group of patients. It's a low volume surgery, and I think that unwarranted variability in the practice is not justifiable. And if you standardize your pathway, you can improve the surgical care you provide to your patients. Thank you.
Thank you very much, George. Very interesting talk, and thank you for sharing your surgical tips with the wider group. So your talk generated a lot of interest and many questions. There were 3 questions asking about the opening pressure of the valve you choose, and how would you change that over the course of the patient management?
So initially, I put the pressure at 15 centimeters of water. So for those not familiar with the Progov valve, the setting is from 0 to 20. So I use a setting of 15, and my decision on that was based that this is the it's a high pressure system, so you don't need to lower the pressure too much. And I was also concerned about collapsing the ventricle to the ventricular catheter and leading to intermittent dysfunction. So I initially put the setting to 15. Then for some patients, Ms. Molan was telling me, well, the papilledema is not reducing to a rate that I would want it to reduce. Could you please drop the valve down? And we were dropping into 5, and the papilledema was reducing. Now, I've changed my practice recently, and I now put the shunts to 10, and we'll have to see how it goes. If it's still not reduced, the papilledema is not reducing quickly enough, we can drop it to 5. It's work in progress, and we haven't still analyzed the ICP recordings to correlate the ICP with a rate of reduction of the papilledema. That's work in progress.
Thank you, George. And there were a couple of questions asking about how would you diagnose shunt failure, and what would you do when you think the shunt is blocked?
Shunt failure in IIH can be either over-drainage or under-drainage. Under-drainage should be, or blockage, in my opinion, should be diagnosed with an examination by an ophthalmologist, so a visual examination. If the papilledema has recurred, then that means that the shunt is not working. In terms of over-drainage, they present with low pressure symptoms. I don't think that a scan, a CT scan and X-rays are particularly helpful when a patient presents to A&E. I would urge people to do a visual assessment first, and if there is papilledema, then go on and image your patients. Now we have also the ICP recording device, and we have the baseline readings, and then we compare them with the readings when the patient presents. And if the reading is high, then this is an indication of course, shunt malfunction. If you, in the initial readings, we get the typical ICP waveform, and then in subsequent readings, this waveform is lost, this again indicates shunt malfunction. Now, there is a small group of patients that it is challenging to diagnose shunt blockage. And I'll pass on, because the discs are atrophic or whatever. So I'll pass on, if you don't mind, to Ms. Mullen to elaborate on this further.
Yeah, so some of our patients, when they've had really good going swelling, get optic atrophy. And in a small group of patients, we've been able to track them, and we have actually seen the disc swell again. But that's actually a very small inflection on the OCT. So that's not only looking at one component of the OCT, it's all 3 components. And we put that together with the headache history. And for example, we've just recently had somebody who had a shunt and then a trauma. And so it's very obvious from that point of view. But sometimes it can be really, really tricky to diagnose.
Thank you both. I might ask, there's another question. I think I'll direct this towards you, please, Susie. The question is, what is considered vision threat? So what's your threshold for placing a shunt in patients with IIH?
This is quite tricky because it's not really well defined in the literature. We've obviously had increased experience, particularly following our national lockdown and COVID, where we've had a huge number in the last 12 months of patients who have visioning threatening papilledema. And so what I'm looking for is full ophthalmic examination, including formal visual fields. I'm looking for changes on the visual fields. Obviously, late changes are things like pupil defects and vision problems and things like that. But particularly in the OCTs, what I'm looking for on the disc volume is I'm looking for fluid actually in the nerve, that's a bad sign, and fluid tracking towards the macula. These things are really, really critical because I know that I'm not going to have a lot of time to, put in place such as a low calorie diet or something like that. There are some patients we challenge with very low calorie diets in the region of 425 calories a day. That's really, really challenging. And I see them back within about 7 days to 10 days to really look for a reduction in their central thickness on their volume scan. The other patients that I challenge are getting them up on a really good dose of Diamox. So we're talking IIH TT treatment child dose of up to 4 grams, and that makes our patients quite sick and nauseous. And again, you need a motivated patient to try and avoid a shunt when you know that you're going to head for serious problems. So it's a combination. And also with the history as well, if patients are having increasing transient visual obscurations, you're starting to notice signs on fields. And really that OCT is something we're very dependent on now in terms of, as I said, the fluid, but also the thickness of the retinal vessels coming out and the fluid around those retinal vessels. Those are all bad signs.
Thank you very much, Susie. I think in your answer, I've answered a couple of more questions regarding the Diamox and also in terms of the follow-up. There's another question about the incidence of CSF rhinorrhea in IIH patients and to manage those patients. George, I don't know whether you want to answer the question.
Yes. So CSF rhinorrhea occurs because of high intracranial pressure, and then the pressure reduces when they start leaking CSF. And when the ENT surgeons repair endoscopically the CSF leak, then the theory is that the pressure again would go high and the optic disc will start swelling, or the leak may recur. So what we do in Birmingham, we repair the CSF leak, and then we assess the patient with in the ophthalmology clinic. And if they develop papilledema, then we manage the papilledema. If the leak recurs, then in those cases we insert a shunt and we repair the leak at approximately the same time or around the same time. But it is not something that we commonly see.
There's another question is, how is the prolonged effect of lumbar puncture explained?
So I think we've got to think about a spectrum of the disease. So there are some patients that absolutely can have one lumbar puncture and put this condition into remission. And there are some patients that need more treatment. And when we think about how long some patients are on Diamox for, I think it kind of shows us the spectrum from one lumbar puncture resolving the disease, not needing any more treatment at all, and other patients really causing much more of an issue. And I think it's really tricky to understand. One, the normal physiology of ICP is still not that well understood. And then the physiology in IIH. And Ahmed, we love your work at Queen's Square. We think it's absolutely fantastic. And some of the work we've been doing here is really focusing in on the IIH patients. And we really hope that come the autumn, the IIH pressure trial will be out, and not only will that show us some of the sort of abnormal IIH physiology we see in these patients, But we also have taken the patients through something we call pressure med, where we challenge the patients for 2 weeks at a time with topiramate, diamoxide, spironolactone, amiloride, just to look and see what's happening for a short period of time. We're not talking about getting patients into remission, but understanding what these drugs do in patients, because it's all well and good doing experiments in the lab, but that's not normal human physiology. So I think it's a fascinating area, and we're going to work out much more in the coming years for it.
I couldn't agree more, and I will look forward for the result of that study, absolutely. There is another question. Would you consider optic nerve fenestration in patients with papilledema as a first choice?
So in the UK, and when we look at the hospital data, it shows very few centres have the necessary skills for optic nerve sheath fenestration. There is a vogue now to use it through the upper lid skin crease, and there's some good retrospective reviews coming out that I've seen literally in the last couple of weeks as well. And, you know, I think it's tricky. Trying to get a patient seen on an emergency basis with the orbital surgeons is challenging. You need to have your pathway set up, but really we need to be starting to think about these surgeries in form of controlled trials, and certainly we'll be heading up one looking at stenting and shunts, and hopefully that will start in the autumn here, and it's a UK multi-centre trial, and so although that's not looking at optic nerve sheath fenestration, I think it's going to tell us the story about stenting and what types of patients are going to benefit from stent over shunt, and actually which ones more effective and actually financially more effective for our national health system. So our experience of optic nerve sheath fenestration in the UK is not as good as United States. So,
thank you, Susan. And one question for you, George, please. Mr. Dasgupta is asking, you mentioned you prefer the sensor reservoir to be put on in line rather than over the burr hole. He's wondering why you're doing that.
Yeah, thanks for your question. It's purely due to surgeon's preference and the technique I use. When I insert the ventricular catheter with a axiom stilet, I set the burr hole deflector at the length that the neuronavigation system tells me where the target is. So, and I use the deflector to angle the ventricular catheter to 90 degrees and then connect it to the inline reservoir. In order to connect it to the burr hole reservoir, to the sensor reservoir, which is 90 degrees, you have to pull the ventricular catheter out of the ventricle a bit to tie the knot and then push it back in. I'm not saying there is right or wrong. I'm not saying one technique is better than the other. I'm just saying that I prefer the inline reservoir because in my hands it works better. But either device will do the same job.
Brilliant. Thank you, George. And there's a question from Zofia Chosnik. I'm very happy to see that she's participating in this webinar. Do you often see KR malformation in IIH patients?
We see it. We don't see it often, but we see it. And the tonsillar descent can be due to 3 pathophysiological mechanisms. It's either a true carry with a normal pressure, it's either due to low pressure from a CSF leak in the spine and traction from below, or to high pressure and pressure from high pressure and from the top with secondary tonsillar descent. And we've treated a few of those patients. We avoid a lumbar puncture to measure the pressure, and we rely only on the ophthalmological examination to diagnose the condition. In those patients, we insert a VP shunt, and in my opinion, that it is a contraindication to insert an LP shunt in those patients because you'll will simply worsen the tonsillar descent. We insert a VP shunt, and in these patients, we often see ascent of the tonsils and the care in quotation mark disappears or improves.
Thank you. There is a question from Magda Garzan asking again, do you rely only on visual compromise for follow-up? I guess that she's meaning whether headache has any role in the surgical decision or surgical revision. So
I'll defer this. I'll deflect this question to Ms. Mullen, because we've moved away from shunting for headache. Susie?
Yeah, so I would say we now have quite good experience treating headache medically with the new CGRP therapies that have come through for migraine has revolutionized some of our chronic headaches in IIH. We've had a number of patients that we've looked after for years, and we've been down the route of lots of different medications and trying to find the right thing. But Botox for migraine and CGRP therapy in our hands has worked very, very well. And so we try desperately to make sure that these patients get managed appropriately and that they don't access emergency care, that they attend their visits so that we can take out things such as medication overuse. They have constant direct contact with the headache nurses to be able to talk, about their abortive medications and their preventative medications. It's a huge area for IIH. And I think in the coming years, we're really going to make inroads so these patients don't bother you guys and they, seek our attention first.
I think shunting for headache is an invitation to many more troubles than the one we're trying to solve.
Absolutely. I think it was a very interesting webinar, and I wish we have more time for more questions, but we need to wrap up. So I would like to thank you both, George and Susie, for the brilliant talks and for answering all these questions. I would like to thank the CSF Task Force and Mr. Farouji for organizing this webinar, and the NS in general, particularly Anna. And I would like to thank all the participants for persisting over the last hour and a half and joining us in this webinar. And I wish you all a very nice evening.
Thank you. Good night.
Good night, everyone.